I've been dispatched to an 18-year-old male who has been hit on the back of the head by a swinging boom on a yacht. He is presenting with pain in the back of the neck and a headache. On arrival, patient is located on the yacht. He's sitting comfortably and alert, with his vitals coming back at a heart rate of 85, blood pressure of 120/80, BGL of 8.2, temperature of 36.5, and a GCS of 15. With a patient such as this, we want to have a high index of suspicion for things such as concussion, traumatic brain injury, or C-spine injury. And after a thorough trauma sweep, we have narrowed down Connor's injuries to just the head and neck, so we can focus on a thorough head and neck assessment. So this is my patient Connor. He's currently sitting comfortably and he's alert to my presence. Initially I want to start off with a musculoskeletal exam, and that'll start off with checking his C-spine, checking his neck and the back of his head to see if there are any injuries, specifically paying attention to his C-spine. So Connor, I'm just going to have a feel around here. Can you tell me if there's any pain down here? No. No? Nothing down the middle?
No.
Okay, and do you have pain here and here?
Yeah, when I move.
Yep, that's where most of your pain has been coming from in your neck?
Yep.
And what sort of movements?
Mostly side to side.
Side to side, okay. And how would you rate that pain out of 10?
Like a 4 or 5?
4 or 5, okay. And is there anything that makes it worse or better?
No.
Just the moving?
Yep.
Is what hurts, okay. So at this stage, Connor doesn't have any midline tenderness and he seems to be moving his head around quite a bit. So at this stage, I can use the Nexus or Canadian C-spine rule criteria to rule out any C-spine injury and go ahead with a rotational assessment. So currently he doesn't have any midline tenderness, he's not intoxicated, he doesn't have any neurological deficit, he hasn't been in a car accident, he's sitting comfortably, and he has a GCS of 15. So I can go ahead and assess Connor's movement of the neck to see how bad his injuries are in the neck. So Connor, can I get you to bring your chin down to your chest? Very good, and back up. And then can I get you to look over your shoulder? And the other one. Is there a lot of pain when you're doing that?
Yep, along there.
Just along the side, okay. And was that pain a 5 again?
Yeah.
Okay, and can I get you to bring, look back as far as you can? Yeah. And bring your ear down to your shoulder. Same on the other side. Cool. So now that he has a pretty decent range of movement in his neck, I'm looking at a potential muscular strain as opposed to a C-spine injury. Lastly, I just want to check his peripheral nerves in his hands. So Connor, I want you to give me a thumbs up. Bring your hand out flat. Paper, scissors, rock, and a rock. Also another okay. So that's checking out his median, ulnar, and radial nerves in his arms that's leading up to the neck, and they're all looking pretty decent at this stage. So we can go ahead and do a neurological assessment. In our neurological assessment, we want to look at sensation, motor function, and cortical function. Initially, Connor's GCS came back as 15, so now we want to go through some memory and orientation. Connor, do you know where we are at the moment?
Pine Harbour.
Pine Harbour, perfect. Do you know what we're on?
Boat.
Boat, great. So, do you know what day of the week it is?
Sunday.
And do you know what year it is?
2018.
Perfect. So, Connor, I want you to remember bird,
Yep.
colour red,
Yep.
and the number 12.
Okay.
Can you repeat those to me?
Bird, red, 12.
Perfect. And can you tell me what this is?
A pen.
And do you know what I use it for?
Right.
Perfect. So far, general observations show Connor's got good speech and language use. He's got facial movements which are symmetrical. Connor, do you have any tingling in your hands or feet?
No.
No tingling anywhere else?
No.
Perfect. Do you have any blurred vision?
No.
Don't see double?
No.
Don't feel sick?
No.
Perfect. So next I'm going to check his sensation and strength. Connor, can I just get you to put your hands out like this? Can you feel this?
Yep.
And this?
Yep.
Perfect. Now can I get you to grab onto both my hands and squeeze? Great. Now can you resist me?
Yep.
Again. Cool. Can I get you to put your feet up here? Can you feel this?
Yep.
And this?
Yep.
All good.
Yep. Yep.
Feel this?
Yep.
Can I get you to push? And this one? Perfect. So Connor's got good strength and sensation. He's not feeling sick at all. Doesn't have any blurred vision or tingling. Lastly, Connor, I just want to check if you can remember those objects and things that we talked about earlier.
Bird, red, and 12.
Perfect. So lastly, I just want to check your mobility when you're walking.
Okay.
So Connor, you're not feeling dizzy at the moment.
No.
Do you think you'll be steady on your feet if you stood up?
Yeah.
Perfect. Do you think you could do that for me? Still feeling okay? Just take a second to steady yourself.
Yep.
And I would like you to jump out of the boat just so I can see you walking. Are you
Okay.
sure you're okay steady on your feet like that?
Yep.
Cool.
Ugh.
So Connor's coordination and stance looks pretty good. Connor, can I just get you to walk down past those dinghies and back? Perfect. So Connor's stance and his gait looks pretty well. It looks coordinated while he's walking, not feeling dizzy or sick when he's standing up, which is looking perfect. In this scenario, blunt force trauma to the back of the head presents a high index of suspicion for concussion, minor traumatic brain injury, or injury to the C-spine. Initially, I wanted to check off injury to the C-spine. I went through the nexus criteria. First, I checked that he didn't have any midline tenderness on palpitation. He didn't have any focal neurological deficit, wasn't intoxicated, didn't have any distracting injuries, and he didn't have an altered level of consciousness or altered mental status. So that came back as a negative nexus criteria. And then following through the Canadian C-spine rule, he wasn't in a car accident, he didn't have delayed onset neck pain, he was sitting comfortably, and he also didn't have any midline tenderness. So using those rules, it allowed me to come to the conclusion that there was unlikely to be any injury to the C-spine, and I could go ahead with further assessment of his neck injury. It's important to check off that there is no C-spine injury initially, right at the beginning, because if he did, then it may mean that he needed to be immobilised, which could impact the rest of our management of the patient for the rest of the assessment. Minor traumatic brain injury assessments were used on my patient as they had a mechanism of injury consistent with traumatic brain injury, along with questions surrounding signs and symptoms of concussion, such as nausea or disturbances in their vision. It's important to assess coordination, as it can determine damage within the brain or the brain stem. Assessing coordination can be used through tests such as the finger to nose test or Romberg's test, along with asking our patient to walk, such as demonstrated in our video. Assessing neurologic elements in patients with trauma to the head and neck is important for determining injury to the brain, spinal cord or nerves. Application of assessments such as sensation, muscular strength and function can aid in determining injuries to these areas. Additionally, peripheral nerve assessments are vital in patients with neck injury, as these nerves are prone to trauma and compression. Those were demonstrated by asking my patient to perform the hand gestures of paper, scissors, rock and the OK, which need to be performed on both sides to ensure that there is no compression or damage to those nerves on either side of the neck.